in the area we're assessing. We're focused on the lumbar spine. There should be no movement in the lumbar spine, and we should see movement at the hips. Go ahead.
Okay, same, we're doing the.
That's it. Come back up, come back up. That's a dissociation assessment. Proximal hold, distal movement, that's our test. Qualitatively, we want to see that the entire inner core engages. So here we're really keyed in on multifidus, but also transabs, pelvic floor, and moving diaphragm. And that the iliacostalis stays quiet, doesn't overfire. If I see a give, now start to bow forward and flex in the lumbar spine. I will say this is a lumbar flexion give. The muscle group that failed are the deep lumbar extensors, the global stabilizers that didn't prevent it. Come back up. If, as you start to bow, anteriorly pelvic tilt, if I see this, this is an extension give. For now, we are going to say that the abdominals, the lumbar flexors, the global stabilizers of the abdominals, failed and allowed her to go into flexion. Thanks.
Oh, no, sorry. That's what I was saying.
I know.
I'm sorry.
Yeah, it's extension. We messed it up.
All right, so now as Taylor flexes, rotate to the right. Oh, as you flex. that was a little pop and
Like
move
this
there, but so now as Taylor flexes, as Taylor bows, she goes into right rotation. So what failed? Left rotators. Which ones? The global stability, that is most likely the obliques. Okay? Now you can think your way through that even further and name the obliques, but for right now that's how you'll answer it. Okay? Now side bend give.
Okay, so I'll go, hold on.
Okay? What's the give?
Left.
Which direction? Right. So there's a right side bend give. So what muscle group failed? Left side benders? The global stabilizers. All right, which are most likely the obliques. Shirley Sarman, she says that your side bending give is most likely a fail of the obliques because they're very good at providing lateral stability. And probably the quadratus lumborum. Okay? Now quadratus lumborum is actually a dual muscle. There is a local quadratus lumborum and there's a global quadratus lumborum. It's just different fibers of the same muscle. So, any give that you see, you will have to name that. So now, we are in a breakout right now, and we are doing a dissociation test. And we are seeing gives or deviations. Do we know why? Although we are in a motor control breakout, we still don't exactly know why. Do we know the driver? We were led here by a driver from the functional assessment, but we don't exactly know the driver of this specific give. We could be unpacking a complex motor issue. So, Taylor flexes, bows, and she flexes. Flex, flex. Okay? Lumbar flexion give. Come back up. We know that there was a failure of the deep lumbar extensors that allowed the flexion give. We don't exactly know why. We don't even know the driver. What can we do to try and figure this out a bit more? We can do a driver assessment. We can do it. I didn't see you said it. Nice. We can do a driver assessment. We can apply external stabilization. In other words, we can apply the method right here. External stabilization, and now bow. Does it get better? All right. So in this case, yeah or no. Yes or no. It does. It does or it doesn't. I could also come into the hip. I'm going to put my hand on your hip, okay, to stabilize. I can come in here and now dance with the joint. So I might actually find that for this particular exercise, which is a motor control exercise, that it's hip driven. So what will I do if it's hip driven? What's my next step?
Hip motor control breakout.
So I might need to follow up with a hip breakout, but what can I do right now to clean this exercise up? Q. So imagine a line from here to here. Draw that together, externally rotate the hip a little bit, and now bow. And come back up. Let's say that helped. That didn't, but let's say that helped.
What am I still giving it to extension? What am I doing?
So yes, you're already in a motor control breakout. We could follow up with a hip breakout, but right now this could clean up the exercise. We know, we were led here. We know that the forward bow is a challenge for our patient. Our patient has pain with brushing her teeth, has pain with trying to lift things up from the floor. We did our a functional assessment. We were led to the lumbar spine, but as we started to unpack this a bit more, we realized that in order to enhance the lumbar control, we have to do a hip cue. So now her exercise is this. Imagine a line between here and here. Externally rotate the hips a little bit. Okay. Ignore that. Now bow forward. Oh, so much better. And come back up. But she gave at a certain point. So you're only allowed to bow forward, right to there.
Darn it.
And then come back up. You need to think about the cue through here. You know what?
Couldn't give it, I just let
Yeah,
it
but
go.
it's a bad cue for you. Imagine the line from the hip drawing into the socket. This is connecting to your spine, and now it is leading through the top of your head, and now forward. No, still not.
Darn it.
Okay.
Because I feel it working, I'm trying so hard.
Rotate your hip in and out.
I'm still giving it to the flexion, or extension, right?
Flexion, you're giving a flexion. Rotate your hip in and out. Okay, now, feel your feet on the ground. Imagine a line from the ground up through the hip. Breathing as it leads through your spine, through the top of your head. Now, as you do this, I want you to feel the hinge in your hip. Feel the hinge in your hip as shift your weight back. There we go. And come back up. Okay, I got to give her a kinesthetic cue. Hinge in the hip. So you're interpreting it as a shift more, but you're actually allowing the hinge in your hip. Now, the reason here is Taylor overcompensates with the upper glute. So she's not getting rid of the upper glute until I give her a kinesthetic cue. Okay? But the point is, this exercise, this is now her exercise. She does bowing, working on the cue. It happens to be a hip cue. For Taylor, it was a little more complex than just a hip cue. But it might just be a hip cue. You work the bow right to the point of the give. Stop there, come back up. What's your dosing? 10 seconds, 10 times. You could do hold right there for 10 seconds and then come back up. Or it could be slow movement forward and back for 10 seconds, then take a break. Up again, slow movement for 10 seconds, take a break and repeat that 10 times. Or you need to practice this for 2 minutes. It takes 2 minutes for your nervous system to start to really change. So I don't care how many you do, even if you only do 3 in 2 minutes. But I want you cued in, plugged into the body, feeling the cue, bowing forward, coming back up. This is your motor control exercise based off of the bow. Happened to be that we had to follow it through. We applied the method, we had to do a hip cue. For someone else, we might have had to do a lumbar cue.
And then would you
A
give me a
multifidus
mirror?
cue.
Like, let's say you wanted to prescribe it to me, home exercise.
So, hold on. So on that, so this is the motor control exercise. We targeted the driver area for this particular exercise, so we had to layer in a cue. How can we help her out? What can we do to make this easier? Add more cues. Maybe that's when we add a mirror. I had to do a kinesthetic cue, but on her own, she can't do a kinesthetic cue. I gave her the experience in therapy, it improved. She looks in the mirror, she uses visual feedback. Okay? How do I progress this? Take away the cue. Okay? How do I progress it further? Add an unstable surface. Foam pad, standing on a BOSU. Challenges the nervous system. She continues to reprogram the nervous system by working on the bows. Okay? That's your motor control breakout, taken into a dissociation exercise, thinking about the muscle that failed, that allowed the give, using motor cueing to try and get her to be able to do this exercise successfully, and then progressing it in the motor control category. Whereas the ultimate progression? Function. Okay? All right. So do the bowing, and patient fake a give, and then therapist name the muscle that failed, or muscle group that failed. Okay?
But for you